Hello everyone. Today, we are going to talk about mitral regurgitation. It comes under diseases of heart valves. So, before coming into the valvular heart diseases, let's talk about the heart. What is the heart? Simply, it is a muscular organ located in the chest cavity, which pumps the oxygenated blood throughout the whole body. The heart is the organ that works constantly during the whole lifetime. The heart has 4 chambers. Namely, the right atrium, right ventricle, left atrium, left ventricle. 4 valves are placed between the cardiac chambers, and from the cardiac chambers to the opening of great vessels. These cardiac valves prevent the backflowing of the blood, and act as one-way inlets and outlets of ventricles. From the right atrium to the right ventricle there is the tricuspid valve. From the right ventricle to the main pulmonary trunk there is the pulmonary valve. From the left atrium to the left ventricle, there is the mitral valve, which is also known as the bicuspid valve. And from the left ventricle to the aorta, there is the aortic valve. The tricuspid valve has 3 cusps and the mitral valve has only 2 cusps. Both pulmonary and aortic valves made of 3 cusps, and they are also known as semilunar valves. So now, let's talk about mitral regurgitation. In mitral regurgitation, there is backflow of blood, from the left ventricle, through the mitral valve into the left atrium. And this happens during the systole of the heart, in which the ventricles are contracted. In mitral regurgitation, there will be abnormalities in the mitral valve, and it will not close tightly. The abnormalities may be due to problems with valve leaflets, valve annulus, damage to chordae tendineae, or papillary muscles. Now, let's talk about the causes of mitral regurgitation. Degenerative disease, ischemic heart disease, rheumatic heart disease, and infective endocarditis are the most frequent causes of mitral regurgitation. There will be damage to the mitral valve in these diseases, making it less compliant. In ischemic heart disease, there can be a myocardial infarction that can damage the papillary muscles, leading to the incompetence of the mitral valve. Papillary muscles give rise to chordae tendineae, which holds the mitral valve leaflets in place, preventing regurgitation of blood. And in myocardial diseases like dilated and hypertrophic cardiomyopathy, there will be dilation of the mitral valve, which can cause mitral regurgitation. Also, there are certain autoimmune diseases like systemic lupus erythematosus, which can lead to mitral incompetence. And collagen vascular diseases like Marfan's syndrome and Ehlers-Danlos syndrome can affect the heart valves and can cause mitral regurgitation. Centrally acting appetite suppressant drugs like fenfluramine, and dopamine agonists like cabergoline, can lead to mitral regurgitation. And now, let's talk about the pathophysiology of mitral regurgitation. In mitral regurgitation, blood will be refluxed into the left atrium, and this will cause increasing of left atrial pressure. With long-term high pressure there will be left atrial dilation. Increased left atrial pressure will eventually affect pulmonary circulation, leading to pulmonary hypertension. There will be total reduction of cardiac output due to the reduction of the blood from the left ventricle, and because of this, there will be enlargement of the left ventricle. Pulmonary hypertension will cause pulmonary edema, which will cause dyspnea. Reduced cardiac output will cause fatigue and lethargy. Now, let's talk about the clinical features of the mitral regurgitation. Dyspnea and orthopnea are features of pulmonary hypertension. Pulmonary hypertension develops as a direct result of the mitral regurgitation. Fatigue and lethargy develop because of reduced cardiac output, as I have mentioned earlier. In the late stage of the disease, the symptoms of right heart failure also occur and eventually lead to congestive heart failure. This will be seen as fluid in the abdomen or ascites, or lower limb swelling. Apart from that, cardiac cachexia may develop in mitral regurgitation. Thromboembolism is less common than in mitral stenosis, but subacute infective endocarditis is more common. On examination, the pulse is regular, but if there's significant left atrial dilation, There can be atrial fibrillation due to conduction abnormalities of the left atrium. The apex beat will be forceful and it will be displaced laterally due to hypertrophy of the left ventricle. Also, a systolic thrill will be evident in severe cases. On auscultation, there will be soft first heart sound due to the incomplete closure of the mitral valve, by the time ventricular systole begins. A pansystolic murmur will be evident due to the presence of regurgitation, throughout the whole systole. Also, a mid-systolic click can be present, and it is produced by the sudden collapse of the mitral valve, and the tensing of the chordae tendineae that occurs during systole. Apart from that, there can be a prominent third heart sound, due to the sudden rush of blood back from the left atrium, into the dilated left ventricle in early diastole. The investigations that are being used to identify mitral regurgitation are chest X-ray, ECG, echocardiogram, and interventional methods like cardiac catheterization. When managing a patient with mitral regurgitation, initially should be focused on the conservative management, especially if there are no signs of severe mitral regurgitation. Since there is a high risk of subacute infective endocarditis, prophylaxis against infective endocarditis should be started as required. However, the best treatment method for mitral regurgitation is mitral valve replacement surgery. If the surgery is awaiting or contraindicated, treatment with drugs like diuretics, ACE inhibitors, or anticoagulants can be given to relieve symptoms of mitral regurgitation.
Hope you enjoyed the video and don't forget to like, comment and subscribe.